Okay, we're going to start. I am so excited to introduce two people that we have has been in and out of our lives for many years because we're always directing questions to them. And Dr. Anne Petru, sorry. Can you make that come up again? Sorry. Is here, who is a professor of pediatrics at UCSF Benioff, but told me right now that she interviewed in the Mish. Remember the Mish? Like the ER was called the Mish 54 years ago. So has been at UCSF for 51 years and has extensive contributions to the field of mother to child transmission, infant HIV, and adolescent HIV, and will be telling us something about history today, along with the cases. And then Rob, where are you? So Rob Newell-Newton is someone whom I know very well, actually, because we were part of the International AIDS meeting, which was supposed to be our first time that the International AIDS Conference came back to San Francisco in 2020. And then there was a rapid pivot to being the first, I think, virtual conference that we ever had. And Rob is extensive experience as an HIV coordinator. He's actually the HIV services coordinator for the pediatric HIV/AIDS program at UCSF Benioff, and also will be telling us about history and cases that are like deeply steeped in what the history of HIV was, mother to child transmission, but importantly, there has to be a mention of what's going on now, and in terms of its effect on the HIV epidemic worldwide. So really looking forward to their presentation, and we'll have back and forth and then questions. We take questions from the audience, but then a lot of people ask online, so I'll moderate those at the end. Okay, thank you so much, Dr.
Thank you so much, and good morning. We're going to take you on a journey from the beginning of the HIV epidemic to the present and to the challenges that we face in our pediatric program as our kids are aging up and out. So if I can do this right without messing up, we'll see whether I can. Yeah, this is who we are. I have nothing to disclose. I was involved in planning and presentation of the activity, but I have no financial relationships. And Rob has one because he's compensated as an advisory board member through Gilead and has sometimes receives honoraria as a speaker. This talk is divided into three parts. The first part will be the history of pediatric HIV in the Bay Area, and we'll then move to a particular case that Dr. Ted Rule and I shared in 2022, and then we'll turn it over to Rob and he'll tell you where we're going and what's happening with adolescents. My patient number one was born in 1980 in San Francisco, and she had a mother who was a nightclub stripper and wasn't in a position to take care of her child. Her child was born with a cleft lip and cleft palate. And I met her when she was almost 3 years old, and she was admitted to our hospital in Oakland with disseminated varicella and concurrently pneumococcal sepsis. During her admission, I got a phone call from Dr. Art Amann. He was the director of pediatric immunology at UCSF, and he had had a patient around the same time who had disseminated Mycobacterium avium. And he wasn't sure why that child had a normal beginning to life and then this overwhelming MAI infection. And he got suspicious and found out that the child had been transfused at birth. And so he tried to track down the recipient of that blood transfusion besides his patient and got a lot of pushback from the blood bank because they didn't want to acknowledge that there was any chance that the blood supply was contaminated with what was starting to appear in the male population in San Francisco. So he spent a year and a half trying to track her down, and eventually he was given her name and contact information because she was living in an adoptive home in a different county with a different name. And that's when he called me, and she happened to be in our hospital at the time. So what he told me was, I think that these two children have the same thing that the men in San Francisco have. But of course, in 1983, we didn't have a name for it yet. And we had no way to prove it. But all we knew was that people who were living with this disease seemed to have a positive P24 antigen. So the adoptive mom gave us permission to draw her blood, and she had a positive P24. So she became my index patient, or patient number one. Nothing was published about kids with HIV for the first 2 years that I took care of her. And so I went to New Jersey, to University Medical Dental School in New Jersey, and visited Dr. Jim Oleski, who was about 15 patients ahead of us in California. And so I went to see what he's doing for these kids. And in the world of pediatric infectious disease, there really was very little need for a chronic outpatient clinic. So we had no methods for tracking and following the patients who came to our clinic. And so I looked at what they had developed, which were, in those days, before computers, paper sheets that had tracking info. What are we going to ask at each visit? What are we going to look for? And how are we going to take care of these patients? So I started with that, but we had still no treatment to offer. I eventually got some support from the hospital to hire a nurse and a social worker, and we opened the doors, and as I said here, in they came. These are two of those very early patients. The one on the left is patient number one that I just described. This is taken when she was a teenager. She had, needless to say, had her cleft lip and palate repaired, and she was living remarkably well, given that there were no meds available for the first 10 or 11 years of her life. The patient on the right is another patient who I adored and looked after. Eventually, we discovered that patients with hemophilia who got factor VIII got HIV, and somewhere between 90 and 98% of hemophiliacs who ever received factor VIII prior to 1986 got HIV infection from their factor VIII. 90 to 98% of hemophiliacs. At our hospital, we had a large hemophilia program, and we had 17 patients with hemophilia and HIV. And this was Jeff. He was one of them. And as a teenager, he wanted to wear this T-shirt to school. Nobody knows I'm HIV positive, in huge letters. And his principal in San Leandro said, I don't feel that it would be safe for you to wear that shirt to school. And so he wasn't allowed to wear the shirt to school. When he went to school and kids would ask him, how come you missed so much school? He'd say, because I have HIV or I have AIDS. And they'd say, no, you don't. His parents invited me to his junior high school graduation because they were afraid that there would be so few people who would recognize him. And as he walked across the stage, I think the reality of what he told all his classmates became true, and he got a standing ovation as he walked across the stage. Our epidemic, starting in 1983 with that patient number one through 2025, is summarized in this slide. We've taken care of over 1,100 patients in the 42 years since the program started. A third of them are children who were infected with HIV. About 2/3 are kids who were exposed but uninfected. So HIV exposed but uninfected, HEU is an abbreviation sometimes used for those infants. 61% were African American, 16% were white, 15% Latino, and 8% other. Of the patients living with HIV, 79% were perinatally infected, and 7% each had received infected blood through transfusions, had hemophilia, or had sexual assault or sexual behaviors that led to their infections. In the early 1980s, we started what we called the transfusion look-back program. We knew that based on our records, about 3,000 patients had received packed cell transfusions before we knew about or had a test to detect HIV infection. 300 of the patients who received those letters responded to them, and of the 300, 17 turned out to be infected. And they had no reason to think that they were infected until we contacted them. So they also joined our patient population. Over the years, we've had 67 deaths, which compared to what you see in the adult world is, in quotes, nothing. But every one of these was an important case to me and to our patients and our families. And as you see in the table on the right, the majority of those patients died in the first 10 years, or most of them died in the first 10 years of life, and many of those long before we had any treatments to offer. In the years since 2019, we've had no deaths in 6 years, which is very satisfying and clearly remarkable. Currently, we follow about 25 to 30 patients, most of them perinatally infected, but now more and more of them are, greater percent certainly are patients who were referred because of sexual behaviors that led to infection, including a patient this week with a viral load of 6 million, a 16-year-old. Our kids live in biological homes with their parents. Some are in foster homes, and a number of them were adopted. Since the COVID pandemic, the number of international adoptions has dramatically been cut down. And so we have hardly any new adopted kids in our program, most of them being internationally adopted and knowing that they were HIV infected. Typically, we would get a call in advance saying that prospective adoptive parents were told that there is a kid in Uganda or South Africa or China or India who we are considering adopting, and we'd like to know what their life will be like if we adopt them and bring them here. And every one of those families brought those kids here to become part of our program. But that was pretty much shut down with COVID. And so we aren't seeing many internationally adopted kids anymore. And as you well know, in the adult world, the treatment has changed dramatically. The picture on the left is an 8-year-old boy who was taking 33 pills a day and 2 little cups of liquid. The first 4 meds, DDI, D4T, sequinavir, and nalfinavir, are all for the HIV infection. And the rest are because he had other physical problems, or he needed to be on prophylactic meds because his numbers were low. He also had some movement disorders, so he was on baclofen and oxybutynin. But that was quite a heavy burden for an 8-year-old. The top right is a 16-year-old, and I realized afterwards that I must have made a mistake taking a picture of this pill box because it only has 6 days a week instead of 7. But in a true week, this kid was taking 27 pills a day, 9 in the morning, 9 at noon, and 9 at night, and she became suicidal. One of the pills was on a research study, and she was dropped from the research study because of her behavior and the fear that she would do some self-harm. And so she ended up coming off the study because of this pill burden. And on the bottom right, you see what is most typical in the adult world, and now more and more in the pediatric world, is that most of our kids are getting a single pill once a day. Our program to match the patient volume is described in this slide. First, it was just me, and then we had a nurse and a social worker. We had additional programs that we got involved with that provided a lot of support, but some of them were of limited duration. California Children's Services is a designated program to support the needs of children with complex problems. And if they qualify for Medi-Cal, they automatically are covered by CCS. And that enables us to bring a nurse and a social worker on and bill for the time that they spend with the patients. In addition, CCS had a beautiful caveat that said if a family, even if they're wealthy and have their own insurance, if they adopt a child knowing that the child has HIV, that child also qualifies for CCS, which provided us with more support. We became part of pediatric branch of the ACTG in 1990. And at that point, we had no drug treatments available. And thereafter, in 2007, we lost our membership in PACTG because the requirement was that you had to have at least 20 new patients per year. And if we did a good job of getting women in care on treatment and gave prophylaxis to babies, we didn't qualify because we didn't have 20 new patients a year, so we lost our funding. In the mid-1990s, a lovely woman who was a dental hygienist married a rich guy named Barry Taylor, and they formed a massive organization and provided us with support to the tune of about $250,000 a year for a few years. They continue to support us, not us, our program, but us, our families, by giving us gift cards for all the families that are in our clinic every year for the holidays. So they gave us about $18,000 worth of gift cards. So every time a family comes to clinic, if they need help with food or transportation, we have a ready, easy way to just hand it to them instead of doing a lot of paperwork to get other sources of funding. We also became part of HRSA's Ryan White Part D in the late 1990s. Originally, and since the beginning, we've called it the Family Care Network in the East Bay, and I'll show you in another slide what that includes. And we're getting somewhere around $900,000 a year for the 6 agencies involved. So for our program, it's a small piece of the big puzzle, but it keeps us connected with our community contacts. And for the last 20 plus years, we've been part of Ryan White Part A, which is handled by Alameda County, and that provides services for mental health and case management for families living in Alameda and Contra Costa counties only. In our pediatric ACTG participation, you see some of the critical things here, especially the top right. PACTG 076 was a study that looked at, can we prevent vertical transmission from mother to child by getting women into care and onto treatment for the last 6 weeks of pregnancy with oral AZT, intravenously during labor, and for the baby for 6 weeks postpartum. So PACTG was an incredible study that was able to show that 2/3 reduction in vertical transmission when women are identified and get into care by 6 weeks before delivery. And as I said, that's why we lost our NIH funding. We did a good job of protecting babies from getting infected. These are the 6 agencies in the East Bay that work with us as part of the Family Care Network. Alameda County Hospital, what we used to call Highland or Alameda Health Systems, is one site for adult care. Sutter Alta Bates is the other site for adult care and some transitional youth care. La Clinica provides mental health services. World is women organized to respond to life-threatening diseases. So it's a support group for women living with HIV. And East Bay Community Law Center provides legal support and services related to the HIV infection. For Ryan White, Part A comes, as I said, through Alameda County and serves just Alameda and Contra Costa kids and provides a little bit of support for our nursing and social work. We also were funded for a while through Gilead in a program called HIV Focus, and we were the only West Coast and only the second pediatric site in the country to participate in this that was called HIV at the front lines of communities in the US. And the goal was to identify people who are at risk for HIV. So our target population was all the kids who come to our teen clinics who are 13 and older, the school-based clinics, the emergency room, and those admitted to the hospital. And we also provide medical support services for the Juvenile Justice Center so that kids who were admitted there could be tested. And through this program, which lasted 3 years, we tested 10,000 children, teenagers, young adults. And of them, we found 7 who had positive HIV tests that were not known to the patient or the family. And 5 of them had acute HIV infection with massive amounts of virus and no antibody. So an antibody screen alone might not have been sufficient. And all of these patients were plugged into care. The requirement to get ongoing funding for HIV Focus is that you had to find about at least 1 in 1,000 patients positive, and we had 0.7 in 1,000. So again, we lost our funding. I'm going to transition a little bit just to talk about the perinatal HIV issues. The major challenge in the last few years has been that when women are in care and on treatment and their disease is really well controlled, their risk of transmission of HIV to their babies through breast milk is dramatically lower than one might have thought. And so for many decades, we said that women living with HIV should never breastfeed. And since 2023, that story has changed. So breastfeeding is now an option through shared decision-making and informed free choice. The mom stays on whatever med regimen she's been prescribed and is monitored every 3 months while breastfeeding, which is probably more often than you might do for an otherwise stable mom. The baby gets preventive medicines until 6 weeks after weaning and lots of labs in between, typically also every 3 months, but depends on how long she breastfeeds. All delivery hospitals in the Bay Area had prohibitions against breastfeeding. Alta Bates in particular had one that said, all women living with HIV may not breastfeed. I mean, it was very clear. And so we had to flip the switch and say, that's not true anymore. And so in order to get everyone on the same page, there are so many people involved in the care when a pregnant woman comes into the clinic that we really needed them all to be in the same place to hear the story so that they would all respond in the same way. So I embarked on a major educational effort to all the hospitals that refer patients to Children's Hospital Oakland, and asked that in any session that I gave that they included obstetrics, neonatology, maternal fetal medicine, nurses, NPs, lactation specialists, social workers, and anybody else who is touching or contacting the women who are living with HIV so that they change their message and they support the decision that a mom might have made. Overall, working with these families is just has been an incredible experience. And when I started in the world of pediatrics and infectious disease, there was no HIV. So it was not my goal to change the world in this way, but something landed in my lap and I took advantage of it in that there was a need and I had an interest and I liked the patient population. So this became my passion. Walking with them through these tough times before and even with good medications. Clinic visits are often far better than remote contact, although with COVID, we were forced to do a lot by remote, but you can't get blood samples that way. And a lot of patients needed to come to our clinic to have their blood drawn anyway. So mostly it's been in person. We provide warm support and work through education and disclosure when the time is optimal for the children mostly, and acknowledge challenges. And we can find clinically significant abnormalities on an exam that a parent might not have recognized or a physician may not have picked up. So when they come to clinic, we offer support to everyone, for the parents, for the patient, for the siblings, if and when requested. And then we work closely with the pediatricians in the community to ensure that they understand what our plans are. So our current pediatric HIV team includes myself, Dr. Anders Newman, who joined us about 5 years ago. He trained in Chicago. He has a lot more experience in adolescent HIV with newly diagnosed infections than I had. And he has taken on picking up all the new patients who come who are identified in our community. We have a nurse practitioner, Ellen James, who is wonderful, spent 20 years in GI before she got sucked by me into our program, and we've just been delighted to have her with us. We have a social worker named Chantel Despiladeras, and we have the wonderful Rob Newells-Newton, who will talk to you after I'm done. The second part of our talk, is going to be about perinatal HIV transmission, and I'm going to tell you about this incredibly challenging patient that we had, and then I'll turn it over to Rob, who will talk about transitioning youth to adult care. Combined, our objectives are to recognize the complexity of treatment for preemie infants with HIV risk and with proven HIV infection, to understand the complex challenges for young perinatally infected adults who've already lived with HIV for more than 20 years by the time they move to the adult world, and to learn ways we might be able to meet those challenges that as we recognize their needs and develop ways to meet them now and in the future. So we're going to flip again. This is a perinatal focus for a few minutes. I already told you that term babies born to infected moms used to have about 25% risk of being infected. And when mothers and preemie babies were higher risk, 50%. But when mom can get into care and on effective treatment, fewer than 1% are infected, which is pretty remarkable. Most transmission occurs late in pregnancy or at delivery. So even if someone is identified partway through the pregnancy, there's still a pretty good chance that their disease can get well controlled. And treatment for the mother works ideally when it started before a pregnancy. So this is obviously the argument that everyone should know their status, whether or not they're pregnant. And infants who are treated aggressively at birth and for 4 to 6 weeks with the right drugs have an incredibly low risk of becoming infected. So then there's this gap. And what do we do about women with a late maternal diagnosis with breastfeeding questions and other infections? So this is the challenging case, the most challenging case we've had in the last 4 years. This is a 29-year-old mom who comes in. She's gravida 5P2, and she has a lot of health challenges with depression and anxiety, limited prenatal care, and ongoing substance use. She presented at 4 months to a Planned Parenthood clinic where they found out that she was indeed pregnant. At 25 weeks, she went to one hospital in Sacramento where the concern was that she might have had premature rupture of membranes, but they weren't ruptured. They gave her betamethasone. She had group B strep positive, and they did a rapid HIV test that was negative. But 3 weeks later, she showed up in Vallejo in a second hospital. Again, this time the question was, is this premature rupture of membranes? And indeed it was. They gave her antibiotics. They screened her and found a lot of drugs that were positive. They did testing for Hep B, Hep A, Hep B, Hep C, GC, and chlamydia. They were all negative. And before they could continue, she left AMA. And then she returned, and then she left again AMA. And the following week, she showed up at Alta Bates Hospital in Berkeley and requested a repeat HIV test because she was told that the partner was sleeping with other people. The drug screen was again positive, this time also with opiates and ecstasy. And her HIV was confirmed with a viral load of 130,000. She also had trichomonas. And so we got an urgent call from Alta Bates for pediatric ID consult. And we at Children's Oakland serve as the consultants for Alta Bates Hospital. So what would you do? Mother is in labor. Is there time to get her on meds? Typically, as I said, in labor, we would use IV AZT to prevent HIV infection, but that only works when it started before the onset of labor. So it may or may not have a benefit. They ordered an oral regimen that included tenofovir, emtricitabine, and dolutegravir. We requested information about the mother's virus, but nothing was known at the time we were getting this information. And with a preemie baby, 50% risk of infection. The other question was the role of cesarean delivery. Cesarean delivery is beneficial if it's done before the onset of labor, and she's already in labor. So that was what was told to her, but she still requested a cesarean delivery because if there was any chance it would be beneficial, she was willing to go through it. But she spontaneously delivered after 6 hours of getting IV ZDV and before other meds were given orally and before a C-section could be performed. So what is the recommended prophylaxis for this infant at this time? All of these regimens include zidovudine. The alternatives are abacavir with 3-TC, nevirapine with 3-TC, dolutegravir with 3-TC, or none of the above. Do I press a button to move on, or does it happen automatically? There you go. So most of you think triple therapy, or half of you think triple therapy with one of the third and fourth choices. We'll see if you can figure out the answer based on what I'm going to tell you now, because you're all wrong. Preemie babies of a certain weight and a certain gestational age qualify for treatment, but not if they're before 32 weeks of gestation. They can't get the triple drug therapy. And if they're not 2 kilos, they can't get some of the drugs. So this is a graph of my patient, the patient I'm talking to you about, and there may be a pointer, but I don't have it. The bottom blue star is his birth weight, 1.2 kilos at 29 weeks gestation. You can see that when he gets to 31 weeks, he's close to an age where we could start treatment, including 3-TC, but we can't because we can't use it. And we don't want to use insufficient numbers of drugs to partially suppress the virus and allow the emergence of drug resistance. And then as he's growing and gets to 37 weeks, he's at 3 kilos, which is pretty nice. He has to be above 37 weeks to get dolutegravir or raltegravir, and he has to be over 32 weeks to get 3-TC. So that bottom left corner is a wastebasket. We don't have a lot of good things to offer, and nothing is better than something that will lead to drug resistance that he deals with the rest of his life. So that's the point of this slide.
And what's the concern? Is the concern toxicity? Like, why couldn't you do it? I understand that there may not be data.
It's mostly toxicity or very little data because there's very little known. And I would probably punt that question to my friend Ted, who is much more involved than I am in the studies that are done of the preemie dosing. We'll come back to that. Okay. So what did we decide to do with this kid? This is the kid the day he came to my clinic. He looks adorable. He doesn't look like a 29-week baby who's 1.3 kilos. We considered prophylactic antiretrovirals for him versus treatment doses until we could prove that he was or wasn't infected. His viral load was sent, but is pending. And so we thought first about high-risk prophylaxis. Could we give him some regimen? And as I've just told you, without reading the details of the slide, we can't use 3-TC till 32 weeks. And so we really were inclined not to use anything rather than to try these. I think that he got a couple of doses of zidovudine before we had more information and made a decision not to treat with a single drug therapy. We also had a lot of questions about breastfeeding, about breast milk, about the drugs that were in mom's body, how many of those drugs in what kind of concentrations are going to have an impact on the baby. Is it beneficial to the baby to have some slight exposure to mom's drugs through the breast milk during this period of weaning from the exposure to mom's drugs? So all these questions came up. Is it potentially beneficial? When should we consider starting breast milk? What is the relationship between the drugs she's taking and the concentration in the breast milk? I didn't know most of that. As it turned out, breast milk, if it's collected and pumped and dumped, it would be reasonable. But when she gets off of her drugs, if she gets off of her drugs, it might be safer to give. But amphetamines persist much longer than cocaine in breast milk. Marijuana is present for up to 67 days. It's a half-life. That's crazy. Breast milk is okay if there's no ongoing substance use. We were told, is she being treated for substance use disorder? Some drugs are okay, some not. Breast milk with a single illicit drug might not be too risky, but if you have multi-drug regimen, as she's been pumping and dumping, might be safer until she's clear of drugs, if she gets clear of drugs. And the hospital was incredibly concerned because if breast milk that's contaminated with HIV is in that fridge and given to the wrong baby, you have a serious problem. And that's a never event that most hospitals don't want to tolerate. So with this baby, the question was, do we put a refrigerator, a little mini refrigerator in her room so that her milk goes in her fridge and never gets mixed with the other milk from other moms in the nursery? As I said, breast milk may be temporizing as the baby may go through withdrawal. So it's not contraindicated by that. Banked milk is not readily available. Milk levels of bictegravir are very low, which I wouldn't have known that, but we did a lot of questioning to figure out what options there are. And the viral load in the mom's breast milk drops by about 1 log per week. So if her viral load in the blood was 130,000 to begin with, it will take about 3 weeks for that viral load to drop sufficiently that breast milk would become safer. So what did we do with the baby? As I said, he was 1.2 kilos at birth, and he lost a little weight first. He needed some oxygen in the nursery. He had a sepsis evaluation. We gave those couple of doses of zidovudine until we got the viral load back at 36 million. And at that point, we said, we can't give him anything more until we have a safe combo of drugs that we can use. The maternal genotype came back without any drug resistance, which was reassuring. And we decided to defer until we could use 3 drugs. Because I'm not expecting any of you to remember or need to use these doses, I'm not going to spend a lot of time talking about the doses that are listed on the slide. But we could have started with zidovudine. Nevirapine is slowly started in any patient, and whenever you start it, you have to add 2 weeks for the first dose. It's not that it's the age or the weight of the baby, but it's the duration of exposure before you increase the dose, because babies are at higher risk of developing skin complications and severe rashes with nevirapine, so it has to be done slowly. But the holdup was the 3TC. And we decided to go at 31.5 weeks rather than wait till 32 because we were so nervous about it. So that's what we did. And for some of the drugs, there's no safe dosing until they're over 2 kilos, as I showed in that graph. So we always want to aim for risk greater than, not to use monotherapy because of the risk being so much greater than the benefit. And when the kid got bigger, we were going to change the drug doses. In those first 3 weeks of life before we got him on treatment, he had fungal infection. He had herpes simplex type 2 with a positive blood PCR and skin lesions, but no evidence of disseminated herpes. He had severe conjunctivitis. It could have been gonorrhea or chlamydia. They hadn't tested it, but we treated him anyway. He also had a spinal tap done because of the herpes, and he had a little bit of blood in his CSF. And with that blood, his herpes PCR was negative, but his HIV PCR was positive. But it was positive with a less than 30 copy viral load. His CD4 baseline and CD8 were fairly reasonable. So our plan for the child was to repeat the viral load on day 14 before starting treatment, and then to use triple therapy with zidovudine, 3TC, and nevirapine. And the long-term plan would have been to change to raltegravir or dolutegravir later. But each of these drugs is complex. I'm going to skip this just in the interest of time, but all of this is slow, careful, thoughtful. Pneumocystis prophylaxis we had to add as well, but not until the baby was about a month old, because pneumocystis doesn't occur in the first 4 weeks of life, but you're adding Bactrim on top of zidovudine and acyclovir, all of which are marrow suppressive. So you're setting yourself up for additional complications. So if you think that's complicated, this is what I ended up doing. My colleague from my department is the one who was attending to this patient's needs at Alta Bates. And my role in the background was to help figure out each step of the way. And what you see divided by the black lines is the complex transitions for doses for each of the drugs. So in the first between the first pair of black lines is just zidovudine. Based on weight, there are 4 different dosing. Based on age and dates, there are transitions in those doses. So you can see that for the smallest babies, you're using 12 per kilo. As they get bigger, you're using 9 per kilo. When they get over 30 kilos, you use 300 milligrams. So very, very complex transitions for each of the drugs. Similarly, with 3TC, there are transitions, but not as complicated. Nevirapine, many transitions, and raltegravir, also challenging. And the challenge for us additionally was that this kid was not in the right weight group at the certain gestational age to get the drugs. So we were, again, holding off on a lot of things. Between week 4 and 10 of life, his weight gain was nice. His med doses were adjusted, as I just sort of showed you. He got prophylaxis for acyclovir after being treated for the acute infection. He got Bactrim for pneumocystis, and he got transfused and erythropoietin because of anemia. His viral load had dropped from 36 million at birth to 395,000 on day of life 16 before he got any treatment. So that was sort of the massive exposure to mom's blood, and then a natural waning, magic waning. And his viral load was 1,000 on day of life 30. We had those challenges because of the weight problem. And here you see a summary. He went from far below the normal child's growth curve because he was born prematurely. But by the time he was 6 months old, he was almost at the 50th percentile, which was beautiful. And on the right, you see his viral load at birth and how dramatically it dropped over the first 3 months of life and stayed undetectable until I transitioned his care and his mom stopped giving him his meds. But that's a separate story. So take-home messages about this baby are that HIV transmission from mother to child can be dramatically decreased from 50% in preemies to 25% in term babies and less than 1% in babies when mom has been diagnosed and treated during the pregnancy. And decisions about antiretrovirals for at-risk infants are complex. The meds need to be chosen and monitored carefully. There are a lot of factors that we have to take into consideration. So with that, I'll wrap up my portion of the slides, and it gives me great pleasure to introduce our HIV Services Coordinator, Rob Newells-Newton. And I'll leave this slide up for a minute.
Good morning. Thank you again, Dr. Petru, for that comprehensive clinical overview. My name is Rob Newells-Newton, and while my title is HIV Services Coordinator for the Pediatric HIV/AIDS Program, I stand before you as a partner in this work. My role is to bridge the gap between the clinical treatment provided by the medical team and the lived realities of our patients. As a person living with HIV for over 20 years myself, I focus on developing services that support the whole person beyond their lab results. You've seen my disclosures. Dr. Petru highlighted the complexities of neonatal infection. We're now seeing the successes of that care, a generation of lifetime survivors reaching adulthood. However, we realized we lacked qualitative data on their long-term psychosocial well-being after they leave pediatrics. The Lifetime Survivors Study was designed as a qualitative inquiry to hear directly from these adults, those born with HIV, about their journey and their needs. To ensure we captured the verbatim truth of these survivors, we utilized technology like Zoom and AI transcription for our interviews. We focused on 4 critical domains: the transition from pediatric to adult care, the strength of their support systems, the persistent weight of stigma, and their current unmet needs in the healthcare system. Our initial pilot engaged 11 participants. By design, every participant in this first sample originated from our own pediatric cohort at UCSF Benioff Children's Hospital, Oakland. This gives us a direct reflection of the medical home we've provided over the years. This data represents a very specific and deeply connected group. Every individual who participated in this pilot was a former patient of Dr. Petru, meaning these insights come directly from the people who were once in the seats of our own pediatric clinics. They aren't just participants, They are the living legacy of the work done in Oakland. From a research advocacy perspective, we prioritize data integrity by choosing not to rely on filtered excerpts. By analyzing the full raw transcripts of every interview, we ensured that the verbatim truth of their experiences remained intact. This allows us to look beyond clinical metrics and understand the full narrative of their transition into adult care, preserving the integrity of their voices as they describe the complexities of their lifelong journey. The early themes are striking. We see a clear transition gap where survivors struggle to move from our high-touch pediatric environment to a more fragmented adult system. There's also a deep hunger for peer support, specifically for people who've never known a life without HIV. While they show incredible resilience, they also carry the weathering effects of lifelong treatment and stigma. This timeline represents more than just medical history. It is the life cycle of a community that many of you have cared for over decades. In the 90s and early 2000s, the focus was understandably on survival, navigating complex regimens with the high-touch safety of a pediatric home. But as these children grew into the teenagers of the 2010s, they encountered the transition cliff. This wasn't just a change in doctors. It was often a sudden loss of the integrated social safety net that had helped them manage the weight of stigma and disclosure since childhood. Now, as we look towards 2026 and beyond, we are defining a new landscape for adult survivorship. We're moving past the era where viral suppression was the only metric of success. Through the Lifetime Survivor Study, we're finally gathering the data needed to address the long-term psychosocial needs that the clinical record doesn't always capture. Initiatives like the Dandelion Gathering are the direct result of this shift, creating a space where these adults can find peer support and build a legacy that isn't defined by their diagnosis, but by their resilience. We're essentially building the bridge that was missing at the edge of that cliff. The most important takeaway for clinical providers is that lifetime survivors are a unique demographic. Their needs, rooted in lifelong medicalization, differ significantly from those of us who acquire HIV as adults. We must address the pediatric cliff, that vulnerable period where they move from a supportive medical home to an autonomous adult system for which they may not feel prepared. This pilot was just the first step. To truly understand these needs, we must expand our reach. We're moving towards collaborations with community-based organizations like the Well Project to capture a more diverse and national landscape of survivor experiences. We've reached a major milestone with UCSF IRB approval to expand recruitment nationally. And through strategic partnerships with the Dandelion Network and NMACS, formerly the National Minority AIDS Council's Lifetime Survivors Network, we're reaching out to women and perinatally acquired survivors across the country to ensure their voices inform our future care models. Our goal for this expansion is threefold: to understand geographic differences in care, to perform an intersectional analysis of how identity affects survival, and to use this data to advocate for policy changes. We want to design adult care models that are actually built for this unique cohort. This is the so what for every clinician in this room. We have been incredibly successful at keeping these children alive and virally suppressed. That's our clinical victory. But the Lifetime Survivor Study data reveals a sobering reality. That very success has inadvertently masked a growing psychosocial crisis. When these survivors leave the protective bubble of this pediatric program and the long-term care they received from Dr. Petru, they aren't just changing clinics. They're entering an adult system that often lacks the integration and high-touch support they've known since birth. We realized that while we were treating the virus with precision, we weren't necessarily preparing the individual for the autonomy, fragmented care, and isolation of the adult medical world. This transition gap isn't a failure of medicine. It's a gap in preparation. It's a signal that Our next evolution of care must focus as much on the transition of the person as we do on the transition of the patient. Data must lead to action. We pivoted what was initially planned to be a traditional clinical forum into the Dandelion Gathering, a community-centric event focused on peer support. We emphasize intergenerational mentorship, connecting our roots, adult alumni survivors, with our seeds and shoots, or current pediatric patients. This creates a sense of medical homecoming. You might ask why we use the term dandelion. In our community, it describes those born with HIV or who acquired it early in childhood. Like the flower, they are resilient. They can grow anywhere. And even when the wind blows them apart, they take root and begin again. To address the lifelong burdens identified in our research, we created a 14-session virtual support group curriculum focused on resilience. For example, because the Lifetime Survivors Study identified stigma as a core challenge, we built specific sessions on disclosure, building trust, and knowing your legal rights when facing discrimination. Finally, we have created tools for you. Our quarterly newsletter, Keeping Up with Youth HIV, translates this research into clinical practice, highlighting the transition cliff and actionable steps providers can take. Beyond the clinic, I serve as the person living with HIV at-large member of the Ryan White Planning Council for Alameda and Contra Costa counties to ensure that this lived experience data informs regional policy and resource allocation. In summary, our goal is to move beyond just treating the virus to supporting a thriving life. By listening to survivors and building programs that reflect their specific needs, we can turn the pediatric cliff into a bridge. Thank you for your commitment to this work.
Okay, so we are going to have questions from both this room and from online. And I guess I just wanted to start, and then anyone could get a question in the room. But in general, we've seen in pediatrics that you can either wait for studies to say that dolutegravir works in infants, or you can extrapolate from the adult literature. So that would be like for antibiotics and cefoxitin and we extrapolate from adults to pediatrics. And I guess my question is, in the world of HIV treatment for children, with the knowledge that you also have that issue of that children can't swallow pills, have you been able to, do you tend to wait for the studies? I think early on it seemed like where I was waiting for studies, like with Indinavir, or do you just take the adult literature and extrapolate as much as you can to adolescents?
I'm not good at remembering names of studies or dates, but I know there was a time when pediatric studies had to follow all of the same phase 1, phase 2, phase 3 steps that adult studies did. And as a result, treatment for children with HIV was delayed for years because they wanted us to do all 3 phases of the studies before the drugs were approved. And then the transition was made when a decision that came out was that if you can show that a dose of a drug in a child is safe and that you can achieve blood levels similar to adult levels, that you can then move forward and start using those same drugs in pediatrics. So that's where we are now. So we don't have to do all of the detailed studies, but what I thought you were going to is can we take these drugs and give them to tiny preemies in order to determine safe doses? And there's so much that's involved in that it hasn't happened yet effectively. I don't know, Ted, if you want to add anything to that.
And I also wanted to, based on that, what you just said, and then Ted, just ask about liquid formulations of drugs for very small, for neonates and for infants.
So there are liquid doses of some drugs, but not all. And for some of the drugs, there are dissolvable pills, and the concentration of the drug in the dissolvable pill is not the same as the concentration of a standard drug. So we've had problems where a patient was given the adult version of a pill rather than the pediatric dissolvable version, which is not safe. So it's complicated.
I don't want to spend too much time talking about this, but the everything that Dr. Petru said is very much true. I think there's been a big push to accelerate how quickly we can get drugs to younger and younger kids. First principle was the kind of extrapolation by drug exposure that Dr. Petru mentioned. Next is moving away from doing trials in series and doing them in parallel. So kind of modeling your way all the way to the youngest possible and then studying it as quickly as possible. So that's what we did with dolutegravir, that sped it up a bit. I think there really is, as you saw from that table, particular challenge in this immediate newborn period, and particularly in for premature infants, where there are just incredibly dramatic changes in the pharmacodynamics in that age group. You see it go from 2 mg per kg to 30 mg per kg. I mean, it's just incredible. And so there's not just great change in individuals, there's a lot of variability, and particularly for insties, it's been really hard. So we can't, what was presented there, we've already moved beyond. We have kind of modeled estimates for nevirapine, for instance, and lamivudine to younger ages now than we did when this child was born already. But for drugs like dolutegravir and raltegravir, it's been harder. So work on that. Yeah, but all great points. I don't want to spend too much time.
First of all, thank you both for great talks. I was curious, I was really interested in the transition from adolescent to adult care. I mean, for those of us providing adult care, I had 2 questions. One is actually around when in adolescence, or how often you're seeing injectable ART started, and if that's helping with adherence and coming to clinic regularly, and what unique challenges they may face in that modality. That's one question. The second is just for those of us who live and work in provider clinics, adult clinics, excuse me. I was curious what stands out as some of the biggest challenges. I mean, we know our healthcare system is labyrinthine, but like what do you think are some of the things that adult providers could do for those youth that are now transitioning to adult clinics to make them feel more welcome and comfortable? Thanks.
So for the question about injectable medications, our clinic is relatively small. We have 25 kids. We graduate 1 or 2 a year. So we have not yet, may never make the transition to injectables because we just don't have enough volume to get the experience and to hire the staff and to be prepared to do that. We have a few patients who have been asking about injectables, and what we do then is what we call a warm handoff, a lot of communication with the clinic that the patient identifies as the one they might feel most comfortable going to. And what we do is we have the conversation with the potential adult provider. The patient has an appointment to go there to meet them. They come back to us and say it worked or it didn't work, or ideally, the adult providers come to our clinic and we see the patient together, so that all the 20 years of history or 15 years of history, we can transition to the adult provider without the patient needing to tell their own story to that degree. So we have not started injectables in our clinic. We have a variety of patients who would be more or less ready. I was telling Annie Lutkemeyer and earlier about a patient that I saw in clinic this week who's 18 years old, but developmentally, she's more like a 13 or 14-year-old. She can't swallow pills yet. She doesn't like shots. She faints when we draw her blood, but her mother is very worried about her not taking her meds consistently when she grows up a little bit further. And so we had the discussion about injectable meds, and mom actually likes the idea because either she or the brother could take her to a clinic and at least they know she's getting her meds. So we haven't started doing that at our site. And I'll let Rob address the other part of the question.
Yeah, what we heard from a lot of our graduates is that when they get to adult care, all of a sudden, they're the person that has to worry about what their insurance is going to cover. And they don't have that. They don't have a social worker there helping them figure that out. They have to ask about their labs rather than Dr. Petru just coming into the room and saying, these are your lab results and this is how you're doing. So it's really the autonomy piece that they're not being prepared for, which is why I think we're doing warm handoffs with like EBAC, East Bay Advanced Care, who we transition a lot of our teens to. They come and do team meetings with us. They meet with the patients together before they transition fully, so that to help those kids kind of grow into their adulthood. But they've gotten so much support throughout their entire lives, and then they're just kind of out there by themselves, having to figure out what the right questions are to ask. So that's been a really big challenge for them going to adult care.
So this is for Dr. Petru. This is one of our ID fellows. If viral load was negative at birth, would you have done fewer than 3 drugs for high-risk prophylaxis and treat as a low-risk perinatal exposure?
So
because of fewer available drugs.
For the because of the prematurity, the risk is considered higher, even if the viral load in the baby was undetectable. So that baby would probably still stay on 3 drugs, at least for a few of the weeks, get all 3, and then maybe just transition to zidovudine alone or to nevirapine alone.
Okay, and then another question from the chat is, what does dolutegravir liquid taste like? Do they wince? I mean,
It's pretty. I mean,
I knew
formulation is pretty well, is much better tolerated. I think this goes to one of your questions earlier about liquid formulations. One of the great advances was the move away from liquid formulations, because classic elixirs taste horribly. I mean, kind of lopinavir was infamous, and really all of them are less well tolerated than tablets. And then the dispersible tablets, by report, is a little chalky, but pretty well tolerated and much better tolerated than the rest. So this move to having unit dosing and weight band dosing was a step forward. And so moving back to kind of liquids is now where we want to go. And unfortunately, you can't treat this dispersible tablet like a liquid because it doesn't disperse evenly. So you can't use it in the same way in a make per kg dosing approach.
And I'll add to that over the years, we had a list of 36 things that parents can do to get their kids to take their meds.
Yeah.
One of them, probably the most famous one, was Nutella. Take a little teaspoon, let them coat their mouth with Nutella, give them the medicine, and then give them a bigger spoon afterwards, because usually kids like that. And that was very successful. The number 36 on the list was put in a G-tube.
Yeah, and I'll just do one quick addendum. I was kind of waiting for the right time. I think this is it. The patient that she presented transitioned to care to the West Bay. And now this child is living with his grandmother in another part of the state and actually doing really well. Had a really, really hard time initially, and we tried Nutella and cherry flavored and grape flavored, and we just this whole giant thing. And now is taking meds without a problem. So it did end well, biologically suppressed, growing and thriving.
Okay, so this is the CME slide, and please take that picture and figure out how to get your CME. And thank you very much, everyone. Thank you so much, Dr. Petru and Rob. It was great. Oh, one more question. I'm sorry. Yeah. I'm so sorry.
And this is for Rob, but it might be relevant for everybody. I'm the psychiatrist at 86, and I've worked with, say, adolescents, young adults with diabetes and other chronic illnesses. And there's really this really tough stage where they're like between 17 and 25 and their friends are partying. They want to live that kind of test the limits life. And I'm just curious how you support your population in both experimenting with being a teenager and a young adult and maintaining their health care.
That's the goal of our Dandelion Gathering, which is going to be August 1st, is to really have some of our graduates from the program who are, our oldest graduate, I think, is 40 years old, work with some of the teenagers so that they can share that experience. Because a lot of what the graduates said is that they didn't know anybody else that was living with HIV as they were growing up. And they still have disclosure issues because of it was a secret their whole lives. So we're going to have that intergenerational dialogue to help so that they can help each other.
And as a final comment, one of the most exciting things about trying to reach these patients is that we tried asking our community doctors to find them for us and nothing worked. So I went back to the chart and called all 40 numbers. I found 27 of the patients. And as Rob told you, 11 of them responded to the survey initially. We're still trying to track them down to get more to come back and respond. But the happy news is that there are 2 patients in our program who graduated who are amazing. One of them came from Zimbabwe and was diagnosed at age 13 with eye disease at Kaiser in Oakland and came to me. It turned out both his parents are infected in Africa. And I got a picture of him last summer in July on the day he graduated from Loma Linda Medical School and was going into occupational medicine. It was a picture of him with his wife and his 6-month-old adorable baby. Oh. The other amazing story was a girl who came from Ethiopia at age 9, ended up in a home with another of our families when her father died. Her mother and her brother died in Ethiopia. Her father died here, and she went to live with another of our clinic families because the father asked us to help him find a place for her. She grew up in the Central Valley, the only Black kid in a community that was mostly on the edge of the farmlands. And she became a psychologist and has agreed to become a psychologist for our graduates who are perinatally infected. And she lives in Texas, but she has a license in California. And one of our generous donors has agreed to pay her for the therapy for any patients whose insurance does not include this practice. So it's just a really beautiful end story to something that started with, really dramatically. Thank you all for your attention.
That therapy resource was something that we offered to all of the people that participated in the Lifetime Survivor Study because we knew it might bring up some memories and stuff. So offering that 6 free therapy sessions was a bonus.
Thank you so much, both of you. Thank you. And next week is the cases from the VA, and then we'll have a C4 seminar in this room right after.